Hi everybody, thanks for allowing me to present my data. I'm Darren Cousins and I'm a consultant in sexual health and HIV based at the Vale Infirmary in Cardiff. So I'm a volunteer member of the steering and leadership group for Fast Track Cities Cardiff and Vale, which is hosted by a charity. We have received pharmaceutical sponsorship in the past for this project and others. And that's about it for my conflict of interest. So in terms of background, we know that there are primary care clusters in Wales, usually for coordinating services for a locality footprint of between 25 and 100,000 population. This is with the aim of promoting the well-being of individuals and communities, and the funding is directly from Welsh Government, but they are independent of the Health Board, although they are administered by the health boards. So we got into there because they're seen as a good way of trialling a new method of practice to deliver healthcare where it's not currently being provided. So Cardiff City and South Cluster has the gleaming Cardiff Bay, gentrified areas, that lots of people live in, but also behind that there is Butetown and Grangetown, some slightly more challenged socioeconomically challenged areas, a little bit cut off from the city as well. Lower proportion of white ethnicity compared to the Cardiff average, and a population increase from 2001, so a lower life expectancy than the rest of the city, despite a greater proportion of children and young people. In Cardiff as a whole, we have a problem with late HIV diagnoses. About 200,000 residents are HIV positive, and I think it's fair to say we have an underdeveloped surveillance system. Until COVID was about, we only had testing for HIV in sexual health services or in GP services. Since then, we've had an online testing platform funded by Welsh Government and Public Health Wales. So we wanted to send an SMS text message out to all adult practice patients for whom a mobile phone number was available, encouraging them to take a HIV test with a link to order a test. We wanted to see if this was acceptable to staff and to patients, measure the uptake of HIV tests and the outcomes of the tests that were requested through this route. So in terms of the patient journey, the patient receives a text from the GP with a hyperlink where they'll be allocated into higher risk or lower risk for HIV. So higher risk would be a man who has sex with other men, someone of sub-Saharan African ethnicity, or someone who's paid or been paid for sex, and a few other characteristics too. If you're lower risk, you go straight through to the Public Health Wales test. So you do get a HIV test, even if you're lower risk. That's one that you do yourself, send off to the lab and get a result back. The higher risk ones you do yourself and read your own test result, like a pregnancy test or a lateral flow test for COVID. So GPs were initially a little bit nervous in the middle of the COVID pandemic to take on extra work, which I think is understandable. Although once the practice was established in the first wave through Butetown Medical Centre, it became clear that there wasn't an excess of workload being generated here. So 5 of the 7 GPs practices completed this evaluation. The other 2 were quite small within the practice as well. So the majority of people in the area were included. 232 people clicked through to the portal, of which 97 were eligible for a home rapid test, and the rest were referred to Public Health Wales testing. Of the rapid kit testers, the majority were men who had sex with other men. Some were of Black African ethnicity, and another third were of a high prevalence country, partner in a higher risk group, or sex workers or contact of commercial sex workers. The street-based sex work areas of Cardiff are within the cluster, so there may well be some local street-based sex workers that haven't accessed care elsewhere. Of the onward referral testers, most are women of white ethnicity and in their 20s and 30s. Of the rapid kit testers, 38% had never tested for HIV. So that's someone who says living as a gay man in the areas who's never actually tested for HIV, which was a surprise to us. 44% had not tested in the last year, or had tested but over a year earlier, and 17% had tested in the last year. And the age distribution really fits the people that we see in clinic, the people who are sexually active. So in terms of the first practice, we looked at workload in some detail to reassure the others, and there were 18 phone calls, mainly points of clarification to say, was this text meant for me? Is everybody being texted, or am I being singled out? So there's a bit of reassurance went on there, but certainly no unhappiness at being tested or being offered a test. We changed our invite to make it clear in the later practices that actually everyone was being asked to consider a test. In terms of costs, we only paid for the higher risk samples, which was negligible. So not a huge number of testing, and there were some promotional materials and costs associated with the brief telephone inquiries, but they were very minimal. Of the 97 rapid home kit tests that were ordered, we got results at about 2/3, which kind of fits with what's happened elsewhere in the UK and internationally. There were 56 negative tests reported, but actually one positive, which was then confirmed in clinic. So that's a man who had sex with a man, a gay man in his 30s who hadn't tested for 5 years. His baseline CD4 was 180, so although he was clinically well, he had a 50% chance of ending up in hospital in the next 2 years, so it prevented a hospital admission, and he became undetectable 6 weeks into his antiretroviral therapy. So really, he is undetectable, he will not pass that virus on to other people. So in terms of conclusions, the testing is feasible and acceptable to local populations in our city. There was an unanticipated positive diagnosis, which prevented an unnecessary hospital admission, to which we're all very glad about. I think there was improved messaging to healthcare and community on the benefits of knowing your status, and I think that's really important. There were no significant barriers to patient take-up reported. And in terms of our discussion, we would suggest that HIV testing really should be routine medical practice. There was some vocalization of outdated practice and treatment paradigms, suggesting that some of these ideas are entrenched outside of HIV treatment centres. I'm an optimist. I see that hearing those conversations mean that I can actually challenge some of those assumptions and stereotypes that are there. And I see that as a positive experience. There's a stimulation of local discussions about how we test people for HIV with appropriate challenge, and the question of who should fund this in future. Is it the clusters? Is it primary care? Is it secondary care? Is it health board? Is it national? And a real challenge to move away from siloed working funding. So in terms of acknowledgements, particularly to Butte Town Health Centre, who were the vanguard of HIV testing this way, and all our partners within Fast Track Cities. So Diolch yn fawr, thank you very much. Any questions, I'll be hopefully present in the discussion.